Good morning, I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute here in Florida. We are in our Melbourne, Florida location, July 13, 2023. Our patient travels to us from Seattle, Washington, with his family. He's young, and he has a really an interesting story, folks. A sad story. He's here, and he's almost lost the ability to move his legs. He's almost completely paralyzed. He's barely able to walk. We had to give him a walker. He cannot walk on his own. He has a very wide base gait. Normally when you walk like this. He's walking like this. And he has severe spasticity in his legs, where his legs are so tight, the muscles, they're just constantly contracted because of spasticity. So he's unable to walk. He's having urinary incontinence episodes where he's having voiding in his pants. And he's got loss of feeling from about T10, which is here down. Turns out he got an MRI done in Seattle at the hospital, and they told him he had a herniated disc at T10, at basically T11, 12, but we're calling it T10, 11 because they miscounted the discs. And that disc herniation is crushing his spinal cord, making him paralyzed. They told him that it was just, pain, and that he just should go home and it would get better on its own. I don't know if they didn't examine him, if they didn't understand the gravity of the situation, but he's basically a spinal cord injury patient at this point. He's 14 years old, and normally we don't operate on 14, but his mother found us out of desperation. We did a telemed, we figured out what was wrong, and now we're gonna do the endoscopic laser surgery to decompress his spinal cord at T10, 11. So that's what we're doing today. This poor young man, I feel horrible for him. He's a basketball star, and he's been unable to do any sports. So the first thing we did before we started the live broadcast, while we were getting everything ready, is we counted from the sacrum up to make sure we're at the right level. And you can see the disc space here on the lateral. Can you see the lateral x-ray, Henry?
Yes, we can.
So show us 10, the vertebral body at 10. Nope, the one above. Nope, yes, that's 10, and the one below is 11. And you can see the disc is abnormal. Look how angled it is. At the front it's collapsed, and in the back it's a little wider, but it's collapsed. But look at the bone spur coming off the back there. Yep, that bone spur tells me this problem with the disc has been there his whole life, for years and years and years. Look at the other discs, they look fine. Nothing wrong with the other discs. There's no bone spurs at the back of them, but there is a bone spur at the back of the 10-11. Now, we're going to get into this from the left side first, and then we're going to work our way over to the right side. But we're going to be taking lots of pictures with the x-ray, and we talk about navigation and localization or confirmation of the level. It's very important when you're doing thoracic spine surgery that you make sure you're operating at the right level. So we're going to be taking a lot of pictures as we set up to do the surgery. He's our first of 5 surgeries today. Again, Seattle, Washington, here to Florida for endoscopic surgery. He's asleep, but we'll give him some numbing medicine to make him more comfortable. He's not a back pain patient, folks. We're not doing this surgery for back pain. We're doing this surgery because he's going paralyzed. If you have questions, I'm happy to answer them for you. When we do our discogram today, it won't be to gauge how much pain he's having, because that's not why we're here. We're here because, like I said, he is going paralyzed and he needs surgery immediately. Shot? All right, so far looking good. Coming around the spine. So I'm getting close. I can feel the facet. I'm going to aim medially as much as I can. I have to get around the ribs as well as the facet joint. All right, so I'm hitting bone. I can't go any further. I'm hitting the facet. Let's go AP. So I'm going to talk to my team and get focused right now. Remember, we are after T10, 11. Shot is a quick shot. Don't set up too long. All right, so I'm too medial. Yeah, look at that. So based on ribs, it's actually 11, 12. So he may actually have 6 lumbar vertebrae. I think that's what he has, is 6 lumbar vertebrae. That explains why the radiologist and I have different numbering. So he actually has 6 lumbar vertebrae. Not something you see very often. All right. Shot? 6 lumbar vertebrae. Fascinating, huh? Shot? All right. Let's get an AP, see where we are, but on the lateral it looks good. You can see how collapsed the disc is. It's wedged because he's blown it out. It's been an injury he's had for a while. That looks great. We're right at the back of the disc. I'm low in the foramen where I want to be. You can see the projection of the disc on that AP view. You're seeing the front of the disc, not the back. Yeah, right there where you see the white is the front of the disc. The back of it is actually much further back. Yep. Let's go back to a lateral view. All right, so we're close. The needle is shifted a little bit since I let go. But shot. All right, I'm inside the disc. I can feel it. There is some bone spur though. There we go. Shot. All right, so that's one in successfully. And we're going to do the next one. Now, before we go any further, I want to again verify levels. So now that we've planted something, let's go down and count down. So we stay where we are. We're going to go down and count down. So we're going to start where we are at 10-11. So based on the MRI on a lateral view from the sacrum up, we are supposed to be at 10-11. So there's 11, 12, 1, 2, 3 at the bottom of the screen. Shot. All right. So I can't really see the top anymore. So let's go back up again so I can see the top. And let's just do cine and come down. All right, so there's 11, right? 12, 1, 2, 3. Cine. Cine on and then move, go. 3, keep going. And then 4, stop. All right, so let's see. We're going to have to count again. I wasn't able to do it with the cine. So let's go, let's see, we see 5 there, right? We all agree 5, then 4, then 3, then 2. So somehow we're going to have to mark that. Yep. So let's do this. Let's go ahead and mark it. Is he comfortable? Huh? No. He's deep. Shot? Really? Is that deep, huh? How come I'm not seeing my needle? Let's go north a little bit. Stop, shot. Wow. So, shot. Okay. All right, I'm right on the bone, shot. Shot. All right, so let's go down south just a little bit. Shot. So 5, 4, 3, 2. Everyone agree we're at 2 if we're counting from the sacrum up. Let's keep going up. Shot. It's a 2, 1, 12. Yep. Show us the top needle. Shot. So 2, 1, 12, 11, 10. Isn't that amazing? He really has 6 vertebrae. Unbelievable. So that's why the other radiologist and I have different counts, because he has more than 5 vertebrae in his back. He has 6. But the good news is I'm 100% sure we're at the right level to fix. You can see how collapsed that disc is compared to the others. Show us all the normal discs. Normal, normal, normal. And then you get to this one and look how collapsed it is. And you see the bone spur coming out the back. So, and it feels, I could feel a tear when I went in. So we're good. We're confirmed our level 100%. I feel confident we're treating the right level, even though he has an abnormal number of vertebrae.
Did you call that L6?
No, we don't call it. I wouldn't call it L6, but you could. I mean, you could say, yeah, you could just say extra lumbar vertebrae. You know, some people could say L6. It really doesn't matter in the end. What matters is you operate on the right level. Let's give some num-num. Shot. All right, so we're coming in from the other side now because we need to go on both sides. The problem with transforaminal surgery, you're coming from the back and you are basically attacking the disc from the back corner, which is great, at a 45-degree angle, but it's hard to get to the middle. There's always going to be some disc left at the middle. Shot. All right, that's where we are. Good. So what you want to try to do is, shot, you want to try to come in as lateral as you can, shot, and attack the disc so you can get as medial as possible, medial towards the midline. Okay? I feel bone, shot. That's touching the transverse, the superior facet, sorry, of T11. All right, so perfect, shot. Yeah, it's very good. Shot. Let's get an AP. Now remember this, for those of you who joined late, this patient is a spinal cord injury patient. We're not doing his surgery for back pain or even radiculopathy. We're doing it for myelopathy. His spinal cord is getting crushed. All right, perfect. So we're right at the mid-pedicular line. Look at those pedicles are massive. And again, if you count from front to back like AP, that looks like we're at 11-12 because the last rib is there. So he actually is missing a rib at the true T12 there, or he has 6 lumbar vertebrae. Either way, it doesn't matter as long as you're operating at the right level, which we are. Shot. All right, so now we're entering the disc from his right side. Shot. We're in. So it's perfect. Okay, this is as good as a result as we could hope for. We're in on both sides, and now we're ready to do a discogram. Now we're not going to do an evocative because we're not interested in pain, but we do want to see the herniation, and this will allow us to do that. You ready? Zoom in. So bring your, center up. Go a little north, just a little bit. So we've already confirmed the level multiple times. I'm comfortable with it. There it is. Look at that disc. What are those things right there? Those buttons, are those, huh?
That's probably buttons.
What are those buttons there? Can we move them?
That's probably,
Huh?
that's probably the gown.
The gown. All right, well, apologize for the buttons, folks. It's his gown. Anyway, you can see the disc we're talking about, how it's collapsed there, and it's angled, and you can see the bone spur. That means it's been there for a long time. So we want to see the herniation, and we're hoping this injection will show us. And shot. Shot. All right. Well, that's interesting. There's definitely some leakage of the dye into the inflammatory zone, maybe some pickup by vascular structure. This is not an AVM, I'm sure of it. This is a herniated disc. You can clearly see it on the MRI. So I'm not worried that we're dealing with a vascular malformation. Now, this is an area where there's an artery we just have to be careful with. And normally we don't damage any arteries during surgery. There's an artery, huh? Domkowitz. That's right. So we just have to be super careful. But in the end, the surgery is absolutely necessary. And that's what we're going to be doing, is operating to decompress the spinal cord. So what's interesting is you don't see the dye outlining the herniation, which means the herniation has been there for a long time, and it's very scarred. Scar tissue does not get picked up by the dye. So this has been going on for a long time, and it's just getting worse and worse for him. All right, we're going to numb up the skin and get started. Once again, this is a patient who's going paralyzed in his legs. He's a T10 partial or incomplete spinal cord injury from a large herniated disc at T10-11. And he can barely walk right now. He's a basketball player, but he can't play basketball. He can barely walk. And once again, they traveled here because the surgeons where they live basically didn't recognize this spinal cord injury. We're going to make a 7mm incision on each side, and we're going to bring our dilator down next. Shot. He's a healthy 14-year-old. Otherwise, we wouldn't be doing his surgery. And normally we don't do 14-year-olds just because kids require different types of care. But he's a mature, skeletally mature. He's muscularly mature. He's physiologically an adult, right? Wouldn't you agree at this point? Yeah. So we're prepared to treat him, and more importantly, the other doctors aren't fixing him. And they're ignoring his problem. So, like so many patients in America and other countries, the doctors don't make the right diagnosis. Now, typically, they don't make the right diagnosis when it comes to back pain and neck pain. But my God, spinal cord injury, that's something everybody should recognize. Everyone, especially in Seattle. Huh? Yeah, we're at the fascia. We're going through his fascia right now. That's why. That's going to be more uncomfortable for him. So, all right, shot. So we're approaching this transforaminal. And you can see the incision is tiny, minimally invasive. We're right at the facet. I'm trying to just sneak around it. Shot. So I'm going to advance this dilator into the disc. This is standard, folks, so don't freak out. I know it looks bad, but it's the right way to do it. This is the way we do it. Is that the guide wire? Yep. Hold on, let me just verify. Yeah, that's good. Uh-huh. All right, we're going into the disc at this point. We're inside the herniation, by the way. We went through the herniation and pushed it back into the disc. Now we're going to take the herniation out using grabbers, surgical grabbers, metal instruments, as well as a laser. The advantage of the laser is it's precise. Precise to 0.5 millimeter. Okay, go ahead. So we're working around the spinal cord, we want to be precise. We're working around the nerves, we want to be precise. And that's what we're going to do. We're starting with the left side, then we'll move to the right side. Questions from the audience?
No current questions, but we just have a couple comments. This first comment comes from Michael on YouTube, commenting, praying for full recovery for this young man.
Thank you. Thank you, Michael. Yeah, we're praying for a full recovery as well. I honestly couldn't believe it when I saw him walk into my clinic yesterday, barely able to walk. I recognized how spastic he was. He looked to me like a patient with cerebral palsy, if you've ever seen them. They're wheelchair bound, and their legs are stiff as a board. They can't control their legs because they've had an injury to their nervous system that prevents their muscles from relaxing, so they're constantly tight. We call it spasticity. And this gentleman, I couldn't believe with my eyes that he walked into my clinic being spastic like he was. It was honestly shocking. that the other doctors did not recognize the seriousness of his spinal cord injury. I didn't get it. But thank God his mom and father chose to act and just not sit there and wait like they told her that he would get better in time. And he didn't get better, he got worse. This is part of the herniation, by the way. It's so big, I'm gonna have to chop it into little pieces with the laser. That laser fiber is 1 millimeter wide. So we're just gonna be taking this thing out a little piece at a time, getting the pressure off the spinal cord. All right, I will take your questions. Again, it's July, 13th, 2023. We're here at the Duke Spine Institute in Melbourne, Florida. And this is our first surgery for the day. We have a long day, 5 surgeries today. We're going to be doing a lot of interesting surgery today if you're interested in watching. We're starting with decompression of the spinal cord for a spinal cord injury patient, 14 years old. Then we're going to move on to a cervical Duke laser disc repair. That patient has 4 herniated discs in her neck, number 4, 5, 5, 6, 6, 7, and C7, T1. She has a very long neck. She is from, where is she from? Pennsylvania, with her family, Pennsylvania. She's here to get a 4-level cervical Duke laser disc repair. And then we have, the next patient is a thoracic Duke plasma rhizotomy. She has thoracic facet pain, both sides. She had a Duke laser disc repair done 4 months ago. Her disc pain is gone. Her radicular pain is gone. But she has now severe facet pain from T6 all the way down to T9 or T10. So we're going to do a bilateral T6, 7, 7, 8, 8, 9, 9, 10 Duke plasma rhizotomy to deaden the pain nerves in her facets. I would like to say as well, yesterday was the official day that we did 10 knees, right, Luis?
No.
Huh?
Yesterday one, what do you mean 10?
We've done 10 knees.
Oh, total. Yeah, oh yeah.
We've done 10 knees. And what am I talking about? Well, those of you who've been with us, by the way, that's bone spur there. Those of you who have been with us, following us, know that we've started doing our Duke plasma rhizotomy for knee pain, people with bad knees. And we've had basically 100% knee pain elimination. All the knee pain gone with a 15-minute procedure that we don't have to replace the joint. We're using a new technology developed at Duke Spine. All of the blue is herniated disc, degenerated disc. Luis, should I buy you a cold vest?
No.
Huh? I think the lumbar scope was the right call, right?
Yeah.
Yeah, for sure. Yeah, we'd never get this out with the thoracic. It's too big. It's too big. Look at all the scar tissue. This has been going on for a long time. This young man, I can tell you right now, that's the end plate there. He has definitely had this for a while. This is not a new problem. There's the tear in the disc, in the annulus. Look at this. This is so hard. It's hard and calcified. Not totally calcified, but pretty darn calcified. It's not like what we talk about in neurosurgery is a calcified meningioma or a calcified disc, but it's on its way. The gold color is calcium. The only way to get that is through calcification or of the disc herniation. You hear about calcified discs. This one is on its way. It's a good thing we got to it before it completely calcified. It would be almost impossible to get out. You'd have to go through the chest. It would be a very major invasive surgery. Any questions from the audience?
No current questions, but we do have a comment from Canes25 saying that bone spur looks nasty. Looks just like the one in my neck pushing on the dura where we suspect I'm leaking.
Yes, you're right. You're right. There's lots of bone spurs in the spine that happen, and we're usually able to get them out with minimally invasive treatment. Like the laser. The laser is very effective. Look at all this scar tissue here. This white stuff, that's what I was talking about earlier. This white stuff is 100% scar tissue from inflammation. This young man has had a disc problem for many years, I can tell. This is literally his entire lifetime. It probably happened during birth, if I had to guess. This is not a herniation that's a couple of years old. This is a very old herniation. That's why he's going paralyzed, folks. The herniation is hard as a rock, huh? Yeah. I remember. All this stuff is mashing on his spinal cord. We are just lateral and anterior to the spinal cord right now. And I'll try to get it out with grabbers, but it won't work. Grabbers are not strong enough. They'll get a little bit, but they're not going to get all that scar tissue. That's the problem with conventional tools like grabbers, is that grabbers are terrible at removing dense tissue. They're good at removing soft tissue, or if the herniation comes out as one giant piece. But how many times have we seen the herniation come out as one giant piece? It's almost never. So the reality is that this is all crushing his spinal cord right here. We're just in front of the spinal cord. The reality is the laser is the best tool for spine surgery. And the problem is other spine surgeons know it. And so they write these articles saying how laser is not good, how it's dangerous, because they realize they're using old technology that's outdated and they don't want to admit it, so instead they write articles and stuff bashing lasers. Now me, I'm a surgeon who's done it all. I've been a fusion surgeon, an artificial disc surgeon, a laminectomy surgeon, a discectomy. I mean, I've done it all. And now I'm into the lasers because I recognize that it's the best tool of all tools. The endoscope and the laser. Those two together can fix 99% of spine problems that are degenerative. Yeah, this is going to be a long one because this scarred up herniation is taking a long time to remove. Now we're never going to get all the herniation out. Nobody can. It's not humanly possible. But we're going to try to get out as much as we can. It's called a debulking. Debulking. And debulking means in surgery where you get most of the mass out. And debulking is common for benign tumors, and it's common for herniated discs, which are benign tumors. A tumor is a growth, a mass, and herniated discs, definitely, they can act like a mass. This is all calcified here.
We have a question.
Sure.
This comes from John on YouTube.
John, hi.
They ask, so this is most likely an injury from birth?
I think it is an injury from birth. Given the fact he's 14 years old, he has no history of trauma in his lifetime, no car accidents. He says he's never had a fall or accident, you know. And so when I started talking to his mom, I asked her about birth trauma, and she said, yeah, he had the umbilical cord wrapped around his neck. They had to do a C-section. It was an emergency. And, you know, doctors, if you've ever seen a C-section, they're literally pulling on the baby to pull him out of that womb. And they pull hard. Now, they pull hard because they don't realize they could be causing an injury, but more importantly, the baby's dying, and they got to get oxygen to the baby. They've got to get the baby's lungs working quickly. And so they're very aggressive, you know, when they're doing C-sections. And so I think that's what happened. If you ask me, that's the most likely scenario for this this patient, unfortunately. So the initial injury happened during the birth process, and of course over the years playing basketball and sports, I'm sure he made the herniation worse. And I'm not saying the doctor did anything wrong that gave birth to him, but they did what they had to do, and unfortunately sometimes people get injured during medical procedures, right? Including giving birth. And I don't think it's below the standard of care in any way, but it's something that more doctors need to be aware of. And that's not something anybody talks about. Look at all this scar tissue. It's unbelievable how much there is. This is why the herniation didn't light up when I put the dye in, because the dye can't get into this white stuff. That's why it's white. The blue stuff is blue because of the dye. The white stuff is white because it's scar tissue. And this is just a huge, like, mountain of scar tissue. Now some people, as we know, when they heal with what's called a hypertrophic scar, right? You've all heard that term, hypertrophic scar. It means that your body scars heavily with inflammation and scar tissue, okay? And some people go beyond hypertrophic and they become what's called a keloider, or they're called what's called a keloider. Keloiders make the most scar tissue. You've seen their keloids. And keloids are actually more common in African Americans. So there could be a genetic basis to the amount of scar tissue that's forming here, you know, because he's 14 to have this much scar tissue. This is at least 14 years of scar tissue. I think his spine injury happened at birth. That's my opinion. I expressed that opinion to him and his mom.
We have another question.
But I think it's important to raise awareness of the problem, because literally I'm probably the first doctor in the world that has ever claimed that there's birth trauma that causes spine injuries. And the reason is because I've seen so many people's MRIs over the years with spine problems. Many of them are children, young adults, adolescents. I've even seen infants, babies, like literally 1-year-old babies with herniated discs, okay? How does that happen? It's trauma. Disc injuries are trauma. People don't understand that. So that's the first thing. Disc injuries are traumatic. Ooh, it's calcified. Very, very tough. It's a good thing we have the laser. We wouldn't be able to do this otherwise. Give me a second. Yeah, we're going to have to bring the laser in. So disc injuries are traumatic injuries. It's something a lot of people don't understand. Damn it. Get that shit out of there. Come on. You're kidding me. This fucking thing won't float out. Sorry for the young ears. So this is a traumatic injury for sure. The question is, when did it occur? And again, based on his lack of history of trauma in his post-birth life, I have to surmise that his injuries occurred when he was being emergently delivered from his mother's womb under fetal distress. I will take the question.
This next question comes from Canes25, once more on YouTube. And they ask, so if they diagnose the spur in my neck as causing my leak, can you fix it all for me, Doc? I mean, if you look at everything and are in agreement with the diagnosis.
Keynes, I only heard, so if you're in agreement with the diagnosis, but spur causing your what now? Leak? Did you say leak?
Yeah, so if they diagnose the spur in my neck as causing my leak, can you fix it all for me, Doc?
No. If you have a spur causing your leak, which you're not going to have, by the way, but if you do, you can potentially go in there and shave the spur down, find the leak, and try to patch it. That is a possibility. However, I think unlikely, but it is a possibility. If that's the case, then sure, I'd be happy to do that. But again, you're making a lot of assumptions. You're making the assumption that your spur is the cause of your leak, and that you even have a leak. So I don't want to get into your history too much here publicly, but are you sure you have a spinal fluid leak? Did we confirm that? I know we've talked about how you can diagnose that, but did we confirm it? And if you tell me you confirmed that you have a spinal fluid leak, and we can confirm 100% without doubt that the bone spur is the cause, then I think it would be reasonable to do that surgery, and I'd be happy to do it for you. But I don't do any surgeries that I don't believe are right for the patient. And you'd have to convince me. I'd have to convince myself through the evidence that's available, through testing. And yeah, we need it. That indeed the leak is coming from the bone spur, okay? I would not do exploratory surgery, like, oh, let's go take a look and see. I don't do exploratory surgeries because I don't need to. The fact is that all my surgeries are planned properly from the beginning. You do exploratory things, that's what happens like with this ocean, what was it called? The Ocean Gate or something? That sub, the Titan?
Ocean Gate, yeah.
Yeah. I don't do that kind of shit. I know exactly what's going to happen before my surgeries. And I know exactly what I need to do. And I don't have surprises. There's definitely surprise surgery in neurosurgery, trust me. See it when I was doing emergency surgeries. You get lots of surprises. But the kind of work that I do now, I plan everything out in advance. So I would have to be 100% convinced you have a leak. I would have to be 100% convinced the leak was causing your symptoms. I'd have to be 100% convinced I could fix it with surgery, for me to do that surgery, and that I could fix it safely, that the risks don't outweigh the benefits. So it's a long conversation, but let's just say you're right and the leak is causing your symptoms and it's coming from the spur. Would I be the one to fix it? Sure, I could do that. As long as the spur is anterior in your spine, then it's certainly something we can do. All right, we are making great progress. Still a giant chunk of scar tissue here. See it? Just
Yes, we do.
amazing. Look at the golden color. What's the golden color? Calcium. So that is a scarred, calcified part of the herniation. And the laser can still get it, but I have to attack it at an angle. We're just about outside of the disc. I mean, we're really right outside the disc. And the spinal cord is going to be just at 12 o'clock up there. I just have to be super careful. Okay, we don't want to put any pressure on the spinal cord. We're coming at it from the side. I don't see the recurrent artery or the artery of Adamkowitz, which is good. Maybe we could see it if we pull back a little more and come out of the disc 100%. But this is what's crushing his spinal cord, all this stuff. And I've debulked it from the inside, and now I'm shaving it down near the surface. Just up there where that band is, you can see that's posterior ligament. The spinal cord is up there. And look at this. This is a calcified part of the herniation. Okay? So it is a beast. I'm going to get rid of as much of it as I can. Remember, we will never get rid of 100. It's not possible. And the more I attack that thing, the more it bleeds. So the bleeding is not a big deal. It's not like he's losing blood, but it's making my visibility poor. And I don't want that. So I need to back off on attacking the calcified portion and focus on the fibrous portion of this herniation. Oh, baby. Felt like something was moving there. You guys see what I'm talking about, the fumarole I created? So let's see if I can get this part here. We're right up against the end plate there. You guys see that?
Yes, we do.
So if I could shave, there's the end plate, the pink. If I could shave a little more, and again, every millimeter in this business matters. Every millimeter counts. If I could just shave a little more out of this bottom corner, I could get a little more pressure off of his spinal cord. He's not moving. We're close to the cord. The pulsations could be vibrating.
We have another question.
Yeah, I'll take your question.
This comes from B3 on YouTube.
Of course.
And they ask, "Hi, Doc.
Hi.
How does the traditional discectomy, laminectomy, artificial disc, and fusion surgery differ from what you do at DSI? And can you explain each and how they differ?"
Yeah, that's a long explanation, so I'll be general. First of all, laminectomy, you're going in the back of the spine. We're coming from the side. When you go in the back of the spine, it's a traditional way surgeons get to the disc or to the nerves. The problem is, to get to those discs and nerves, they have to remove the roof of your spine. The roof is the normal roof. There's nothing wrong with your lamina. So they're taking out normal things like your lamina in order to try to get down and fix a problem that they're actually not fixing. So the problem with all these spine diseases, the problem is always three things. Number one, you have pain and it's coming from the disc or the facets. 90% of the time it's the disc. So you got to fix the disc. Number two, you have spinal stenosis causing pinched nerves. That leads to leg or arm weakness, numbness, tingling. So you got to unpinch the nerves in a lot of patients. Number three, you got facet pain as your second cause of back pain. So there's three goals to surgery. Get rid of pain, unpinch nerves. Two goals, right? But there's three things that cause it. Stenosis causes the pinched nerves, and the disc tear, annular tear, causes the disc pain, and the facet arthritis causes the facet pain. So there's really only three things you have to do in spine surgery, degenerative spine surgery, and that is get rid of disc pain, get rid of facet pain, and unpinch nerves. Now, a laminectomy doesn't get rid of disc pain, it doesn't get rid of facet pain, it makes both of those worse. And all it can do is try to unpinch the nerves by opening the back of the spine, which doesn't even do it, because the nerves are being pinched by the herniated disc, which is what we're fixing right now, okay? So a laminectomy doesn't get rid of disc pain, doesn't get rid of facet pain, and it doesn't do a great job of unpinching the nerves, because the nerves aren't pinched where the lamina is, they're pinched to the side of the lamina where the facet joint is. So you'd actually have to remove the facet joint or part of it to get rid of the pinch, okay? You start removing, this is a newer herniation, by the way, the blue stuff there. If you start getting rid of your facet joints, guess what? That patient gets instability. Woohoo, it's calcified. That patient gets instability. Look at the needle on the other side. You guys see it? I know it's hard, but you see it right there?
Yes,
under the blue, there's a needle. We're about to connect one side to the other, all right? Good stuff. So basically, laminectomy doesn't fix anything that needs to be fixed. That's the problem. Second of all, discectomy, all they're doing is they're doing a laminectomy, which we've already established is bad because it's taken away your normal stabilizing structures, like your ligaments, your muscle, your bone, your facets, okay? Then they go beyond that and they start picking at your herniation. Now that treatment is only for leg symptoms, like sciatica or weakness, numbness, tingling, right? Doesn't do anything to fix your pain. So ask your surgeon, hey, if you do a microdiscectomy, will my back pain go away? The answer will be no. We don't do microdiscectomies for back pain. Okay, it's true, they don't. Nobody does. They do it for leg weakness, numbness, tingling, which most people don't, they're like, okay, that's important, but that's not my main problem. Most people's problem is pain in the back or pain down the leg. So discectomy and laminectomy don't fix it, okay? So then you've got Fusion's great. It works if you do it right. Problem is most doctors don't do it right. We do it right at Duke Spine. We can get rid of your back pain. We can get rid of your leg symptoms because we do a decompression with the fusion. Okay? Got to do both. All right, just about done with this side. And then finally, artificial discs. They're a joke. They don't work. They pop out. They cause all kinds of problems. They were supposed to preserve movement, but turns out they fuse most of the time, in my opinion. They hide that data from you. And then they're supposed to get rid of pain, but they make the pain worse in most people. And then, of course, they fail. They fall out. Plus, you're getting a piece of metal in your body. Why do you want metal in your body? Who wants metal? Nobody. So that's why I don't think those surgeries are any good. The Duke laser disc repair, we go straight to what causes the symptoms. It's the herniated disc 90% of the time. By fixing the herniated disc, you fix the stenosis, you fix the pain, then if you need to, you do some facet treatment and get rid of the rest of the pain. All right, don't grab onto the back of the pituitary. Oh yeah, there's a piece. You know what I mean?
Yeah.
Just pinch and let release. That will work every time for you. We're just about done. He I don't think he doesn't have really any pain in here. I think he had a little bit of pain, but his main problem is he's paralyzed. Almost completely paralyzed. All right, so there's my needle. I'm just trying to get the last of this. See how dense it is? It's right up against the spinal cord. Just between the top edge and there is the spinal cord. So I can't get any more with the grabbers. I'm going to come in with the laser one more time. I've removed about 70%. We never get 100, so don't expect it, right? People ask me, aren't you going to get it all? Why does my MRI not look that different? We're not trying to make your MRI look different. In his case, we're trying to make his MRI look different. But most importantly, we're trying to get the pressure off his spinal cord so he can walk again. Yeah, we don't do spine. That's right, Dr. Berndes. I need to use that more. We don't do spinal cosmetic surgery. We're not here to make your MRI look pretty. You guys have all been lied to all these years, you know. I'm sorry you have, but surgery isn't supposed to make your spine look pretty. It's supposed to fix your pain, fix your pinched nerves. And we can do that without making your spine look pretty on an MRI. All right, this is as shaved back as I can get. We are literally at the back edge of the disc. I can't safely go any further back. I am at the limit, but I can shave a little bit more here. I'm sorry the visibility sucks. That's the bleeding that I stirred up from digging into that calcified disc. Right? All right, questions?
This next question comes from John, once more on YouTube.
Hi, John.
They asked, a buddy of mine from the Army just had a fusion recently performed by the VA. According to his docs, fusion was his only option as his hips weren't connected to his spine correctly. Part 2. According to the VA docs, his upper body was coming down onto his leg nerves. So with no support, his legs were failing. Are there cases when fusion is only resort?
No, they lied to him. Fusion, when they say to him, fusion's your only option, what they're saying is fusion's the only option we can offer you. All right? It's kind of like if you're caught in battle by the enemy and they line you up on the ground and tell you to put your hand on your head and kneel. And they say, sorry, we don't have any food for you, so our only option is to execute you. That's not their only option. That's their only option they're willing to do. They're going to execute you. You're dead, okay? But that's not your only option. And they lied to him. His option was exactly what I'm doing here. And this would have been his best option. All right, irrigation. Let's go. Put a little bit of antiseptic in there. They lied to him. The VA lies all the time. The VA is not interested in spending money on soldiers or retired soldiers, period. Okay? Well, I have served the veterans for years. All right, just so you understand, when I was a resident, I worked at the VA in Gainesville, second busiest VA hospital in the country. Okay? And I took care of the vets all the time. Those vets deserve better, but the VA system did not have the financial resources to take care of them. How's he doing? Stable? So that was a bloodier disc than I normally deal with because of the amount of inflammation. He's got a lot of blood vessels around the back of the disc. When you get a herniated disc, remember you get a tear in the back of the disc. There's really no blood supply at that point. However, over time, the herniation causes inflammation. And when you have inflammation happening for years upon years upon years, like this patient has, what it does is it creates a call out. Your body, your disc calls out for more it calls out for more blood, basically. Put it back. Or you can put the guide wire. It's fine. Your body is calling out for blood supply because inflammation is your body attacking something. And when you're attacking something, you need energy, lots of energy. Energy. So your body is attacking that herniation with inflammation, trying to get rid of it. So the area over there where the tear and herniation is, it's saying, give us more blood, give us more blood, give us more glucose, more oxygen, take away this metabolic byproducts. So it literally sends out signals to the blood vessels in the area saying, come over here, we need you. And more blood vessels grow over here. You guys could see that. With the discogram, when we injected dye in the disc, there was some venous filling. So there's a lot of veins and arteries in this area. And he has some venous bleeding, which is more than we normally see. So we're just going to wait a minute. I'm going to give it a chance to stop. I don't think it's muscular. I think it's from the annular tear that we just removed. So we've gotten about half of the herniation out. We've got to get the other side done. But I want to make sure that he's okay, he's safe, he's stable before we move any further. So I'm just going to work with, let's keep an eye on everything. We're just going to wait a minute. All right, we'll take questions at this point, but I'm sorry, the truth of the VA system, yeah, it was clogged, is that when I was there for 7 years as a resident, and then I took care of VA patients, veteran patients for years, like 10 years when I got done. I came to Brevard County from 2004 to 2014, 15. I was taking care of VA patients. And the VA, it didn't pay you very well, but at least it paid, Medicare rate. But what happened is, in an effort to save even more money, the VA stopped paying doctors and hospitals. They slowed down the process of approving treatments. Oh, we're going to wait a minute.
Oh, you're gonna wait?
Yeah. And then they basically did everything they could to put the brakes on treatment for vets. When I was there in the VA hospital in Gainesville as a neurosurgeon, taking care of vets with back and neck problems and brain problems, we had veterans with hip problems, knee problems, and they would tell us it took them 2 years just to get into the doctor. So they go on a waiting list for 2 years. And really what the VA is doing is they're hoping that they die so they don't have to take care of them. Okay? That's wrong. They shouldn't do that. They should create more resources. And the thing about it is we had a 6-month waiting list for neurosurgery. So my co-resident and I said, we went to the Department of Neurosurgery, we said, hey, we would like to have more clinics, we would like to have more patients in the clinic, because we were only seeing maybe 15 patients a day, and between 2 neurosurgeons, we could easily see 50 to 60 in a day. We were seeing 15, so we could have tripled or quadrupled the number of patients. But they came back and said, no, we're not changing the scheduling system. They have a software they use, and they said the software cannot be adjusted or manipulated. In other words, you can't put more patients on. And we're like, well, why? We're sitting around a clinic, we got plenty of time, we want to help these people, there's a backlog of 6 months, let's get them in, let's get them seen, let's get them taken care of. And they said no. That came straight from the director, okay? So the VA system doesn't want to care for the patients, they want to care for more of the patients. They want to care for less. All right, the bleeding is stopped. I don't feel any hematoma, but I'm going to give it another minute just to be 1,000% sure, because I want to make sure before we go to the other side we don't have any issues. Nope. No, it's not that kind of bleeding. These are big vein bleeding. Not like, you know, not like the internal, huh? No, it's not capillary. This is epidural vein that's engorged kind of bleeding. In other words, normally you have your epidural veins, Batson's plexus with blood going in, but when you have a lot of blood flow in that area because of inflammation, it's almost like a vascular malformation where you have a higher flow, higher dynamic through that area. That's what we're seeing. Inflammatory mediators, that's exactly what it is. So, pretty fascinating if you think about it, right? Yeah, but imagine that happening for 14 years. Inflammation nonstop, 14 years in that spot. A lot of blood supply to that area. It calls in collateral circulation, we call it, and it gets very vascular. That was more vascular than I expected, all right? But it was also more calcified than I expected. There were parts of that herniation that were rock. I don't know if you saw that. So, I don't know. I have no idea what to expect. That's why I'm waiting. I want to make sure we're good on this side. I think we will be. All right, so at this point, summarizing what we know, this patient is basically a T10-11 spinal cord injury coming here. And it's been getting worse. He's almost not able to walk. We had to give him a walker because he's so spastic. And the reason he's this is because he had a massive herniation right here pushing on his spinal cord. You could see it on the MRI. It's been there a long time. We didn't know that. We kind of knew it based on the history of injury during birth and no other trauma. But what you can't tell is that there is some parts of it that are heavily calcified. And there are parts of it that are lightly calcified, and there are parts of it that are not calcified at all. So you could see the blue stuff, which is a newer herniation. You see the white stuff, which is scar tissue, so it's older inflammation area. And then you got the gold stuff, which is calcified older inflammation. And you got the calcified part, which is rock hard, and that's the part that was bleeding the most, is what's called diploic bleeding, bone bleeding. All right, you ready? I don't see a hematoma. I don't feel a hematoma. It's supple, so it's nice. Keep a little pressure for a minute. Watch out for that. All right, we're going to move on to the other side like we intended. I feel it's safe to progress. I'm checking with my anesthesiologist. How are we doing, Dr. Berndez? Is he stable? He looks good. He looks stable. So we're going to move to the other side. All right. Yeah, I'm just worried because of the amount of inflammation. But if we don't get this side, he's still going to have weakness in his leg, spasticity. So it's be really good if we could do this side. Yeah, I think our position is good. All right. We okay to proceed, you think?
Yes.
I agree. Vitals are stable? Yes?
Yes.
Let's just look one more time. Looks good. 7 millimeters. Little bit of soft tissue ooze, but nothing serious. Keep pressure there, please. All right. Vitals are good. Heart rate's good.
Heart rate hasn't changed at all.
Heart rate hasn't changed. All right.
The key on both sides.
Well, we need to do both sides. I mean, if I don't do both sides, he's going to still have problems. He's going to have another surgery. So I want to get this done. I feel it's okay to proceed. Any questions from our audience?
Yes, we have a question from B3, once more on YouTube.
7 millimeter incision.
They ask,
Shot.
how does the connectivity between the femoral nerves, the sciatic nerve, and lumbar discs, and potentially other factors, help in the diagnostic process to determine specific lumbar segment is effective?
Well, so there's two main nerves that go into your legs from your back. One is the femoral nerve, the other is the sciatic nerve. The femoral nerve is in the front. It primarily innervates things that are in your upper leg, upper thigh basically. And then the sciatic is down the back of your leg, and it primarily innervates things below the knee. But it does get the hamstrings and things in the back of the leg. So just different distributions. Let me have the knife. I'm going to open 1 more millimeter. It's a little tight. Still good? Shot? All right, so I'm basically following my guide wire down to the disc. I need to do some num-num because I'm at the fascia. That may be what he's feeling. The fascia has nerves, pain nerves in it, so it does hurt when you poke through it. So I'm trying to give him some relief. I'd like to do a pressure dressing, Luis, when we're done.
Also, I was thinking about putting an abdominal binder, just like we do with the spinal cord.
Sure.
Trials or in the
I think it's fine. I like it. I like it. You know, I like it. I went down, no resistance. Everything felt good. We're right at the herniation again. So remember, we are dealing with a herniation that's very firm, scarred up, and calcified in some parts. The entire herniation is not calcified. But let me see. Where are we? Shot. Entering the herniation. Shot. Abdominal binder for. She's at $12.99. All right. Any questions?
Yes, we have a question from Rafa on YouTube. And they said, hi, Dr. Resulta Frami discogram. They said I had to be fused at L23 AMD. They were unable to check L5 to S1 Dueno pre.
Whoa. Did you understand that? Because
I'm just reading it as is. I can repeat it once more.
Try it again.
Hi, Dr. Resulta Frami discogram. They said have to fuse L2 to L3 AMD. They were unable to check L5 to S1.
Yeah, okay, I get it. So to answer your question, no, you don't need a fusion. We can fix you without fusion. When doctors tell you you need a fusion, it's because that's all they know how to do. They don't know the more advanced endoscopic surgeries, folks. Endoscopic spine surgery is going to take over. It is the safest, most effective treatment in the world. Much better than fusions. It's faster recovery. This is outpatient surgery, and it's safer. We have less blood loss, less complications. There's no need for you to have a fusion. And we can fix you. You just need to do a visit with us, okay? All right, we're inside the disc. You can see the herniation. And I'm going to try to grab some out if I can, see what I can grab. Remember, this is a very firm herniation, so I'll probably just have to bring the laser in. 10 minutes. All right, great question though. So you do not need a fusion. Folks, just because someone tells you need a fusion doesn't mean you need a fusion. That just means that's all they know how to offer you. Okay, but it's not what's best for you.
Is that other software working on the other side? This bag over there? Okay.
People have to understand something about doctors. They're going to offer you what they have available. That's it. Okay? If there's something better out there they don't have available, they're not going to offer it to you. That's most doctors, unfortunately. Now, me, I'm not that way. I was brought up differently. I was brought up to always offer the patient what's best. And guess what? 95% of neurosurgery, I'm not the best. I'm not the best. So I will not do their surgery. If they have an aneurysm, I won't do it. I will tell them, you need to go to Shands Hospital in Gainesville and get the best aneurysm surgeon over there. If they have a pediatric problem, like a tumor, I'm not going to operate on those patients. I'm not going to say, yeah, I'm the guy for you. I'll take that brain tumor out of your kid. Because there's far better surgeons than me to do that. I know that my limitations are. So I don't lie to people and tell them your best treatment is a fusion, because that's not. That's the best treatment if you, number one, you're dishonest, and number two, that's all you know how to do is fusion and laminectomies and stuff. But when you know how to do endoscopic laser surgery, it opens up a whole new portal for opportunities. I like that portal word. You guys like that? Portal? That's an ode to The Witcher.
I won't give him any Toradol at all.
What?
I won't give him any Toradol.
Yeah.
Just verifying.
He'll have pain. So this side you're seeing the herniation is kind of blue. Means that it's being stained by the dye that we use. It means it's a younger herniation on this side.
You okay with Robaxin intravenous for him?
What?
Robaxin?
Yeah, yeah, of course.
I just want to make sure.
Yeah.
I'm just signing the order.
I think it's fine. I mean, we may even be okay with Toradol, but let's try to reserve it.
Right, exactly.
We're almost done with this patient's surgery. We've got about 10 minutes left on this side, and then we're going to be recovering him, and he'll go home with his parents today. Now, he traveled from Seattle, Washington to Florida for the surgery, so he's going to have to stay in a hotel overnight, and we're going to check on him in the morning. All of my patients we operate on, they get my cell phone number. They can call me anytime if they have any problems, including them. We do have a hospital 5 minutes away, and we've had to activate it, EMS before. Not for my patients for the most part, but we do a lot of pain management, and sometimes those patients have low sugars or they get palpitations or something, and we have to get the EMS involved. All right, grab her. Any other questions?
Yes, we have another question from John once more on YouTube,
Hi, John.
asking, isn't the DLDR much easier than fusion anyway?
Great question, John. Is the DLDR easier for me? Easier for my team? Yes, it's easier for everybody. It's easier for the anesthesiologist, easier for the patient, easier for my team, easier for me, easier for the patient's family, easier for everybody. Everybody. It's even a lot cheaper than a fusion for the insurance companies. But, you know, the truth is that the companies that sell the screws and rods, they don't want DLDR. They don't want my surgery because we're taking their business away. And they want fusion. No, more than 5. This is pretty firm here. It's probably a good 8 to 10. All right. Unfortunately, his disc here is just abnormal in terms of being just firm, very firm. And this part that I was at earlier, that was deeper, so it wasn't as vascular. But this part that's more vascular, near the surface, seems to be more scarred up. Yeah, I think we need a few more minutes. Look at that, huge herniation, all scarred up. It'd be nice if this came out in one piece. It's too much to hope for. We've seen those. This is a giant herniation. I'm gonna have to cut it with the laser. By the way, for those who say laser is not necessary, not useful, they don't know what they're talking about. Look at the laser. Well, I couldn't do the surgery without it. This surgery, I wouldn't even do it. I would not do the surgery without a laser. It's impossible. No, you're not going to fix the patient. So it is intellectually dishonest. Yeah, for other people to say that. But for me to do the surgery without a laser would be intellectually dishonest. I can't do this. The grabber cannot get this stuff by itself. 99% of the time, we need the laser to break these pieces up into smaller pieces to get them out, right? Because they just don't want to come out on their own as a big piece. All right, we just got that last big piece to get out. I think we're going to get it too. I really feel good about it. You can see the end plate, by the way, the bone over there. That's the what we're calling T10, inferior end plate. Just about there. Look at that herniation, all that scar tissue, inflammation. See the pink stuff? Inflammation. Inflammatory tissue, little blood vessels. Oh, look at that calcium. That thing is hard as a rock. It's like a rhino's horn. Right, Luis? All right. Any questions, comments?
Yes, we have a comment and a question. This first comment comes from Jim,
Hi, Jim.
and they ask, isn't the I'll be there when the Medicare pays.
You'll be there when Medicare pays. Good for you, Jim. Good luck getting Medicare to pay, my friend. But it's good to know, Jim, that you trust Medicare so much. I don't know if you're saying that because you can't afford it, or if you're saying that because you trust Medicare's judgment. I'd be interested to know, but folks, Medicare is an insurance company. They're run by Blue Cross, Cigna, United. They are for profit. And they make money when you don't get medical care, when they deny things. When they deny payment, they save money for Medicare, they get compensated. They make money by denying your care. No, just like the VA system does. I was talking about the VA system earlier. I was saying that we used to take the VA, but they stopped paying back in around 2014-15. We would do the same surgeries on the same types of patients. They went from paying Medicare rates to paying nothing and just denying. So what? They almost wiped out, anesthesia at the VA. So what happened was, the VA said, how can we save more money? And of course, the insurance company said, we'll save you money. And they said, how? And they said, just let us manage the claims. What managing the claims means let us pay the bills to the doctors and hospitals. So Medicare, VA said, okay. Well, guess what they did? They didn't pay the bills. What they did was they would send you a letter saying, we need more information on the surgery, on the procedure, on the office. Send us more documents before we pay. So we would, of course, send documents, everything they asked for, and then they would not pay. And we would call and say, why aren't you guys paying? And they say, we never got the documents. So we would send them again. Of course, all this is taking a year, right, of correspondence and no non-respondents. So we would send the documents again, confirm where we sent it. They would confirm receiving it, and then we wouldn't get paid again. And then we would call again, and then somebody would say, oh, I'm new, and we never received the documents. And they played that game with lots of doctors and hospitals. And basically, we were just losing so much money. We couldn't stay in business. We had to stop providing free care. And then VA said, oh, you guys are creating a lot of problems for the VA hospital, you payers. Let's try another one. So they switched to a different paying system. And they hired 2 processors, both, again, private insurance companies, wolves dressed as sheep, and they didn't pay either. They went lower than Medicare, but that wasn't even the problem. 0 is lower than Medicare. We got 0. So they wouldn't pay, and it wasn't us. And then finally, it came into the news, 1 million providers nationwide not paid by VA contractors. So it's just a game, you know. They keep saying, oh, shame on us. We picked the wrong ones. I'm so sorry. We'll hire somebody new. And they all do the same thing. And then it's just, how long will doctors and hospitals can survive on treating VA patients for free when there's money set aside to pay for their benefits, and it's not being used to pay the doctors or hospitals. It's being siphoned off by Epic. Epic. Corruption at its finest. The electronic medical record system. Literally a software program, folks. We used to pay $50 for them when I was a younger kid. Somebody made a complicated game software. You paid $50. You got a CD. You upload it on your computer, and then you can play the game. $50. Well, Epic has embezzled $6 billion from the VA system for their EMR. They should be arrested. And of course, the system still hasn't been uploaded and implemented because now they're saying their projected cost is $50 billion. So it went from $5 billion or $3 billion to $50 billion over 10 years. How is this possible? They knew it was going to be, they were going to scalp the VA and the government, and they just lied. It's a bait and switch, the old bait and switch. So why is our government allowing it? Because they're in on it. The politicians and the VA administrators that run the VA, they're getting kickbacks. Don't ask me how. Don't ask me how Hunter Biden got deals with China for energy and things like that. But I can tell you, I can't tell you exactly how it happened, but I can tell you that the people that need the money and medical care are not getting it at the VA. And it's because of these corrupt politicians and administrators. That's a fact. That comes from somebody who was inside the system and a provider who took care of the vets and watched it evolve over the years. It's a shame because we used to take care of vets all the time. Now we can't treat them because they don't pay for them. Anyway, Medicare is no different. Medicare, half of our patients that come here are Medicare patients. So as you watch these surgeries be done, know that 50% of our patients have Medicare. Why are they getting the surgery done if Medicare won't pay for it? It's simple. They know it's the best surgery. It's the only one that really works. And they're willing to pay for it themselves. And they should. When your insurance doesn't cover something, what do? It doesn't mean you go without, especially if it's your health. It means you find a way to pay. Now, if you guys are unhappy about the fact Medicare doesn't pay for it, I'm happy you're unhappy because I'm unhappy too. So we need to have a grassroots effort where the people that have Medicare go back to Medicare and say, hey, pay for better care. Pay for better care for us. After all, you guys paid into Medicare your whole life while you were working. Assuming you worked, you paid into Medicare. So you should demand more from Medicare. Look at all this scarred up disc. That's amazing. You can see there's a fresh herniation, the blue stuff, down at the bottom there, right against the end plate. But Medicare is no different than the VA system. They don't care if you get care or not. They just don't want to pay for it. And if they can get away with not paying, they'll keep getting away with not paying. Because the people that facilitate the non-payment are the ones that are benefiting from the non-payment. And that's the claims processors. All right. probably 8 minutes at this point, burned as the problem is as I got closer to the surface, it's getting more come on, Luis. It's getting more calcified. Let me show you. It's literally a pinch pull, just like that. You don't pull it like this because it won't go. You pull it from the side. Any other questions?
Yes, we have a question from B3 once more on YouTube. They ask, how do you differentiate between the nucleus and the annulus fibrosis? Sometimes I can see the dyed area being removed, and other times is the debris from the herniation, what I believe to be the nucleus. I have sent my MRI almost 4 weeks ago, and my pain has been increasing, and I'm eager to get properly diagnosed.
So you sent your MRI 4 weeks ago. Did anybody contact you?
We will await for a response.
And did you fill out the form? Did you get an email? Because if you do it right, you're supposed to fill out the form online and get an email response confirming we received your form. And then you've got to send your MRI either by UPS or FedEx or upload it onto the website through the portal. And if you don't do that stuff, then there's no way we could have your MRI. We're not going to be able to do your MRI review. People can't just send the MRI here and expect us to do an MRI review. You have to fill out the form. We have to get your name, your email address, all that jazz. All right, again, we're right at the back of the disc here. Right at the back of the spinal canal, at the back of the disc, and front of the spinal canal, I apologize. There's so much scar tissue here, and I'm going to try to get as much of that as I can. We're right there, you can see that. I'm going to try to chip away, okay? It would have been nice if this was fixed years ago, because I think it could have been soft disc herniation then, rather than calcified hard herniation. I think with the amount of herniation we removed so far, that he's going to do very well. Here's the tear, recent tear. You can see how the whole mass of scar tissue here has lifted off of the end plate, literally just pulled away. It's become mobile, like a giant moving mass. So going back to the midline. I'd say 3 minutes. See what I'm talking about here? Literally, I'm taking it to the maximum of what I can do. But that thing is pretty damn solid. I'm going to try to get some more of it out with the grabber one more time. What do you think about Grabzilla? Let's get Grabzilla out here. Grabzilla. Go, 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 quickly. We're going to try ripping some of that stuff out with a more powerful grabber we have. It may work, it may not. It's worth a try. Once again, we won't get 100% of the herniation, we never do. But we're going to try a little Grabzilla. That felt pretty good. Oh yeah. Ugh. Holy macazoid. Ugh. Let's take a peek. You guys got to turn. Ladies, come on. Scope was out and you guys left it on. Okay? I don't mind socializing, but We got to pay attention to what's going on in the OR. All right. Let the dust clear. Just don't see much. We've sort of stirred up a little bit of bleeding. This may have pushed in a little. That may be why. Yeah, that's why. All right, let's try Grabzola again. Take this. I'm going to hold this. Scope needs to go off, aids. Hold that. It's going to want to go in, don't let it go in. It's going to want to go in, don't let it go in. There you go. You feel it pushing down? Damn it. Not much. Yeah, I think we've taken what we can. Let's go one more time. One more look. We've pretty much maxed out what can be removed. And I just want to just do one more look, one more try. Maybe a little bit there I can get with the laser. Remember, I can't get 100, laser on. I can get maybe 50, 60%. If I'm lucky, 70. But that should be enough to get the pressure off his spinal cord. All right, that's as good as we can do. I can't do any better than that. Well, I hope and pray it's enough for this patient. Little antiseptic. I don't need, I just need a little antiseptic, then the irrigation. All right. Good. We're going to wake our patient up. We're going to put a couple of staples in. We'll take them out tomorrow. And we're going to do a dressing that gives some pressure on the muscles so that we don't get any bleeding into the muscles. That looks good. Any questions, type them up. I'll answer them for you in a few minutes as soon as I get out of the operating room. I call EBL 20 pressure here. Sure. That should make him feel better, not have any issues. All right, type your questions up. I'm happy to answer them for you. I got it. Take care of that. I'm going to show you the incisions in just a moment. I'm very happy overall. We did everything we could do safely to get the herniation out. I think we probably got 50, 60%. So that should help him a lot with his legs. The thing about spinal cord injuries is that he is going to take time to heal. And that's normal. Okay? It takes time to heal. How's his temperature? Good? Vitals stable? All right, Henry, I'm going to show you the incisions real quick.
Copy that.
We had to do 2 incisions. One on his left flank. You guys see it?
Yes, we do.
And then one on the right. Same size. Yeah, our next case is going to be a cervical Duke laser disc repair. We're going to fix 4 discs in the neck. Type your questions up. I'll come answer them for you in a few minutes. But overall, I feel very optimistic. He'll do well. Just have to get him recovered and out of here. back to his family. You ready? That one's fine. You want to do that one first? Huh? You have a stapler? Yeah. Two's good. You don't need to wipe. Just put it there. You know it's there. Perfect. All right, we can put 2 here. Yeah, that's a great idea, Luis. Thank you. Sure, I'm going to put your stapler here. Great job, everybody. Tough case. I'll come answer your questions. Henry, go ahead and show our audience how the Duke laser disc repair actually works.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Good morning, it's February 22nd, 2023. I'm Dr. Duke Machen. I'm here with one of my patients who traveled to Duke Spine Institute, not too far away from Jacksonville.
That's correct.
Yep.
That's where we're from.
You found out about Duke Spine through the internet.
Yes, I did.
And why did you end up coming here?
I ended up coming here because I could not get rid of the pain that I had in my back and in my leg. I tried to exercise. I tried every physical therapy, yoga, everything you could think of, and I just could not get out of it. It just would linger and linger and linger, and it wouldn't go away.
How long have you had that back pain for?
This back pain has lasted me for the last 6 years. It started when I was working at the garden stores, doing a lot of heavy lifting. I took some time off from it, and then I jumped back into work, and the pain, just when COVID hit, I just had gotten a job in a garden, took another job in the garden store, and shot down my leg, and it's been like that. The pain's been like that for 2 years. So, you know, now it's 2023, and came here to see you, and yesterday we had it done, and in 1 day I'm doing a lot better now.
So you had the Duke laser disc repair done yesterday at L45L5S1. You could see us in there with a tiny 7mm incision, the endoscope and the laser, cleaning out your disc. And clearly, to me, the disc did look injured, like they were about 5 to 10 years of injury. So it's been going on for a while for you. And you have degenerative disc disease. So a lot of people ask me, does the laser surgery work to get rid of back pain and leg pain when it's degenerative disc disease? What would you say? Sitting here now.
Yeah, I mean, my worry was that, you know, the disc had gotten just so bad that it wasn't really replaceable, that, you know, I was recommending a fusion. And I certainly did not want that. When the pain came on, I researched and found you and said, no, I don't have to do that. I don't want to have to do that. That's just not right.
Yeah, so you had degenerative disc disease at L45, L5S1, but you had back pain coming from them. We did the laser surgery, we didn't do fusion. Is your back pain still there?
No, it's
Gone.
gone. It's gone.
Yeah. And the pain in your right leg, down the back of your right leg, is that still there?
That's gone.
Gone. Now, is it gone because we put you on narcotic painkillers and you're loaded up on morphine right now?
Yep. No pain medicine, no anything.
So what did you take after the surgery? You took a Tylenol,
Tylenol,
Robaxin,
Robaxin.
and are you still
fact-
taking them, or are you using them?
I took them this morning. In fact, so I didn't even take them right after. Went to dinner after this, and yesterday went to the hotel, slept real well, and got back up. And
So no
things are looking
narcotics. You've been
And-
up walking around.
Yeah,
The surgery was
and
outpatient.
At 62, this is my time to really concentrate on my health and get back to the exercises and the walking I want to do, the swimming I want to do, the bicycle I want to do, the living, not the existing.
Exactly. Living, because you're
Not
not limited by
still
pain
more.
anymore.
Yeah, and maybe I was a judge was good. We did disability over the phone because of COVID, and he awarded me that.
Congratulations.
And that was 2 years ago. But I don't want to depend upon the government. I want to go out and get working again.
You may not need disability anymore. What do you think?
That's where I'm going.
I want to mention one more thing.
Sure.
You did have surgery already before you came to
And
me.
that's another thing.
You had laminectomy.
Yeah.
Did it work for you?
I have to say, it may have worked only because my first surgery, and I stopped the work that I was doing at the Jacksonville Zoo and Gardens. I'm a horticulturist, so.
But if it worked,
But it,
you wouldn't be
be
here having
here
another
prob-
surgery.
no.
So did it
Because
work for you? Did it take away your back pain?
No, it didn't. Not in the long run.
Did it
No,
take
because it
away your
weakened the
leg
spine.
pain down your leg?
No.
No. So the problem with laminectomy is people feel good maybe for a little while, a few
That's
months,
right.
maybe a year, but then because they've removed all the bones and ligaments
That's exactly-
from your spine, it causes things to get worse.
That's
And they're
what-
not addressing the disc. The disc is actually the cause of all the pain.
Right.
And they didn't fix your disc.
No, because when I had that surgery, I stopped the job I was doing, took time off, and went back and boom, it went back in.
Okay, so as soon as you got active again, the pain came back.
That's right.
Yeah, that's the problem, is that you really just limited your activities rather than fixing the source of the pain. Laminectomy doesn't do that, doesn't fix the source of the pain. The Duke laser disc repair does. Well, congratulations. I'm
Great.
happy for you.
Great.
And I'm excited for you and the rest of
Sure.
your life. 62, you're going to start enjoying life and doing all the things you want to do. But remember to
Absolutely.
let it heal first, okay?
Yeah, we're gonna let it heal. And before I put that big heavy guitar on me, because I am a guitarist.
Of course, there you go.
So-
Anything you want to say to your musical fans out there?
Just remember, keep on rocking in the free world. If you need some help, come to this man. He is amazing.
Yeah, we got a Leonard Skinner fan, right?
Yeah, I love the Southern rock.
All right, thank you. All right, well, I hope you enjoyed hearing from one of our patients in the past, a testimonial. And we just completed a difficult surgery, a challenging surgery. On the MRI, you see a herniation at thoracic spine, at the bottom of the thoracic spine, clearly crushing the spinal cord and causing this young man to be basically going paralyzed. He was pretty close to not being able to walk anymore. As a matter of fact, when I saw him in clinic yesterday, he was so spastic with his legs that he literally had trouble walking. He was so stiff and tight that he was on the verge of falling. He's fallen a few times, he told me. He's had trouble controlling his bladder. He's having accidents. 14 years old, basketball star, and now almost paralyzed. Misdiagnosed by the doctors in Seattle at the Children's Hospital, unfortunately. And they told him, yeah, just basically give it time and it'll get better. That's what they told the mom. That's what she told me. I recognized immediately that there was a problem with the spinal cord being crushed, and he was extremely symptomatic from it. So we recommended surgery right away. That was about a month ago. They showed up yesterday, and here they are today. We did him first, because it is the more challenging surgery of the day. And I decided, looking at his MRI, because his spinal cord was getting crushed on both sides. So this is the spinal cord. It was getting hit by a giant herniation across the back, but on both sides plus the middle. So I figured if I attacked it from both sides and did the maximum amount of removal of that herniation with my endoscope, that I would be able to get most of the cord decompressed. Hopefully it worked. The surgery went well. It was a bit challenging. Patient was in great shape physiologically. He's an adult, and everything went great from a vital standpoint. But we did have some challenges in that there were parts of the back of the disc that were calcified, hard, and they bled. So it made it hard for us to see, but we were able to get everything seen and done. So in the end, I was happy. Of course, we as surgeons, we always want more. So if you can get out 60% of something and that's enough to get the patient healed properly, then you of course want 70, 80, 90, right? But the problem is when you start pushing the limit of surgery, then you get complications, and we don't want a complication with this young man. Could I have gotten 100% of the disc? Absolutely, I could get 100%, but he'd end up paralyzed. So that's not worth it. All right, I'd rather preserve his function and not injure other parts of his body to try to get 100%. There's no point. If you're creating new problems for the patient while trying to fix a problem, then you got to ask yourself, is the creation of the new problems worse than the original problem? And if the answer is yes, then you shouldn't be creating the new problems as a doctor. You have to really temper your goals and enthusiasm to achieve those goals with the reality that you're not treating an MRI, you're treating a human being, and they have a life to live, and what you do in the operating room could have a permanent effect on the rest of their life. And that's why we're so against fusion surgeries, because fusion surgeries are permanently stiffening and putting metal in your spine. And there's so many of them being done, and I say they're unnecessary because we have an alternative surgery, the Duke laser disc repair, the Duke plasma rhizotomy, that is non-invasive, that will fix people's back and neck pain without fusion. So are fusion surgeries necessary? Yes. In a world that doesn't have Duke laser disc repair and Duke plasma rhizotomy, they are necessary. Are fusion surgeries necessary when you have endoscopic Duke laser disc repair? They are no longer necessary. And of course, we're talking about fusions for degenerative disc disease, degenerative stenosis, facet disease. Not talking about fusions for tumors, fractures, dislocations, things like that. Of course, we still need fusions for those serious types of injuries to the spine. All right, we'll take questions.
This, as of now, the only question we have is from cmoney317 on YouTube. And
For those of you who don't remember, I am a gator, as well as a Trojan, as well as a Trident. Triton.
Go guys. Anyways, no, but from the question from C-Money, I think this is just seeking for advice. They said, I just went to a neurosurgeon for a bulging disc in my C5 that's pinching nerve root, and he recommended an artificial disc replacement. I'm 35 with kids who are active with sports, and I am hesitant.
Yeah, so C-Money. Are you friends with a famous boxer?
Oh, yeah.
Floyd Mayweather?
Oh, yeah.
What does he call himself?
He just goes Money Mayweather.
Money Mayweather.
Yeah.
All right, C-Money. To answer your question, you have a bulging disc. It probably needs surgery to fix it, okay? However, an artificial disc is an old technology, and your surgeon is offering it to you because they don't know how to do endoscopic surgery. That is the next level of evolution. You understand what I'm saying? And it is far better than putting a hunk of metal in your neck, whether you do a fusion or artificial disc. I wouldn't do it. Artificial discs cause complications. You get scarring, you get trouble swallowing, you get hoarseness that change your voice permanently from the scar tissue. A lot of artificial discs have complications. They tilt to the side, they get loose, they cause heterotopic ossification, they cause fusion of the segment, they cause adjacent segment disease. All those bad things happen with artificial discs. All right, and that's if you don't have a real complication like an infection or fracture from them or spinal cord injury. So all those bad things happen with artificial discs. Now, you hear about some people having good results. Of course, some people have good results. Some people have good results with fusion. Some people have good results with injecting cobra venom into their body, right? But the problem is those treatments are not predictable and they're not reliable, and they don't consistently give you great results with no complications. The only surgery that does that is the Duke laser disc repair. Now we're about to do another surgery on a lady who's traveled here from Pennsylvania, and I think Pennsylvania. We have another one from Iowa, but I think that's later in the day. So this lady from Pennsylvania, we're doing her next. She's getting Idaho. She's getting 4 herniations in her neck done. Literally, you're going to see me fix 4. You only need 1 done. Very easy to do. It takes us 30 minutes. You get to go home the next day. But the next surgery will be a 4-level. I wouldn't do the artificial disc, my friend. I would do the laser surgery. Save up and get the laser done.
And that is it for questions.
Wow, just one real question. All right. Well, enjoy the day, and we're going to be here for a long time. We've got 4 more surgeries to do.